Yes.
Yes, sir. Good to go.
Yeah. Good evening, friends. Today we start the 37th webinar of Pudukkottai Budan, an online weekly webinar meetings from ISA Pudukkottai branch, Tamil Nadu, India. This is our 37th episode, and on behalf of ISA Pudukkottai branch, I extend my warm greetings and welcome to everybody who are in here. At the outset, today we have 3 different topics covering various aspects of anesthesiology, and I welcome our academic chairman, Dr. A.L. Meenakshi Sundaram sir, who is the brain behind this Pudukkottai Budan, which is a successful venture going on very popularly. I welcome you, sir. Today we have Associate Professor Dr. V.J. Karthik from Kilpak Medical College, Chennai, who has consented to be the chairperson of this CME. I welcome you, sir, Dr. V.J. Karthik. And we have 3 different speakers, all from Udaipur, Rajasthan. First topic regarding uncontrolled hypertensive patient posted for gastric perforation, exploratory laparotomy, and Dr. Sakshi Thakur, Assistant Professor of Ananda Institute of Medical Sciences, Udaipur, Rajasthan, is going to talk on that. I welcome you, madam. Next topic regarding acute lung injury, and Dr. Nirdesh Thakur, Assistant Professor from Ananda Institute of Medical Sciences, Udaipur, Rajasthan, is going to talk on that. I welcome you, Dr. Nirdesh, for today's event. And the third, Dr. Kunal Modi, resident from Geetanjali Medical Center, Udaipur, Rajasthan. He will talk on carbon monoxide poisoning.
Thank you so much,
welcome,
sir.
Dr. Kunal.
Thank you so much.
Welcome every delegate, senior anesthesiologists, professors, office bearers of our branch, state branches, and India, from all over India, who have assembled here for this CME. I welcome you all again. Regarding this TNMSC credit hours, you can follow in credit points by attending this CME, and you put your questions in the chat box so that it will be taken by our chairperson and our academic chairman joined together. We will have a fruitful and useful discussion following the 3 speeches. Now I hand over all the proceedings to our academic chairman, Dr. A.L. Meenakshi Sundaram sir. Over to Dr. A.L. please.
Thank you, Dr. Suresh Kumar, President ISA Pudukkottai. I welcome all of you gathered here for this webinar, and it is highly surprising. Even I can't even imagine that we have crossed 37 smooth weeks, that 37 weeks uninterrupted webinar with 4 faculty. It is not a single faculty, it is 4 faculty, and we are thankful to the entire country. And crossing the border, everyone helped us to run this webinar successfully. And today we have specialist faculty from the state of Camel. So these people are having the tallest stature like the camel, but they don't have any bumps. They have straight away, they scored good marks in their curriculum. And our youngest faculty today is Dr. Kunal Modi, who is having that charm in his face, just like a bachelor's face. But soon he is going to last it, because next month he is going to get married and he wants to deliver a lecture as a bachelor. And I think this will be the first webinar for him, but it doesn't look like a first webinar. He's talking like a seasoned person. Probably he would have got the experience from his Vagdatta Vadu. So that girl with whom that betrothal has happened, she would have trained. I was told that she is also a doctor. Dr. Kunal Modi has pursued his MBBS from Geetanjali Medical College, and he is currently a final year MD in the Geetanjali Medical College, Udaipur, Rajasthan, and he is having the passion towards organ transplant and palliative care, and we wish him a happy married life and a good curricular as well as extracurricular life. So the second faculty will be Dr. Sakshi Thakur. She has pursued anesthesia from SMS Medical College, Jaipur. So SMS is Sriman Singh Medical College, Jaipur, and he has done 3 years senior residency in the prestigious All India Institute of Medical Sciences, New Delhi, and she has not stopped with that. She has also pursued Dependent anesthesia and a certificate course in palliative care and European diploma in anesthesia and intensive care. She has 7 years of experience in anesthesiology, and every year she has published a paper. So for the 7 years, she has published 7 papers, and she is currently working as a assistant professor in Ananda Institute of Medical Sciences, Udaipur, Rajasthan. But she is having another interesting part. First, we will talk about Dr. Nirdesh Thakur. Dr. Nirdesh Thakur has pursued MD anesthesia from SMS Medical College. Now you would have got the point. Dr. Sakshi also studied in the same SMS Medical College, Sriman Singh Medical College, and he has also done MD post-graduation at the same time when she was pursuing her MD anesthesia course. So there was a lot of conversation in SMS, not in medical college, in SMS by the phone, mobile phone, lot of conversation by SMS and WhatsApp. But even with that, Dr. Nirdesh has completed his FNB in critical care medicine from Gangaram Hospital, New Delhi. And he also cleared the European diploma in intensive care. For the same reason, Dr. Sakshi is also doing the same. So he was also doing the same. And he had 1 year observership in ECMO from Sweden. So he has acquired knowledge from there also. And he has also have the same 7 years experience in intensive care as an intensivist. So Sakshi has cleared 7 papers in 7 years, and he has cleared 7 years in intensive care. So it means in anesthesia department, they were mutually anesthetized by each other, and they are continuing as a happiest couple in anesthesia as well as in extracurricular life also. So we wish them all the very best. And Dr. Nirdesh is working as an ICU consultant now. So they are together in the anesthesia field. Luckily, if one is a surgeon, they would have quarreled among each other. But as they are anesthetist, they are supplementing each other, and they are leading a wonderful life. So very congratulations for them. And now, as I used to say, the difficult part is arranging a chairperson, because these three are topmost faculty. So we want to place an associate professor in the name of Dr. B.J. Karthik. Karthik is a very, very interesting personality. He has wide knowledge in all the field of anesthesiology. So he's not particular about one field, but he is particular about one field. He has a passion for work. He is a workaholic, and Dr. Karthik is now the associate professor at Kilpak Medical College, Kilpak, Chennai. But he's the one who has won with a huge margin in the ISA secretary election in Chennai. So in metropolitan city, the knowing each other will be very difficult. But Dr. Vijay Karthik met everyone in the metropolitan city of Chennai, and now he is presently the active secretary of Chennai city branch. And I request all the four to be familiar with our webinar. So once again, we are happy to host all of you. Routinely, the first thing will go to the junior most person. Dr. Kunal Modi will be talking for 10 minutes on carbon monoxide poisoning. It will be followed by Dr. Nirdesh. At least here he can supersede his spouse. So as the third is the interesting topic as gastric perforation, people will be eagerly waiting. So Madam can cover it at as a third faculty, and questions will be at the end of all the 3 lectures. And I request the chairperson to clear the questions first in the chat box, then it will be open for all. Now I hand over the proceedings to Dr. BJ Karthik to carry on the scientific session. Sir, over to you.
Sir, very good evening to all, and my respected professor and dean, sir, ALM, sir. It is a very big honor for me to get recognized by a senior person like you, sir. I worked under you when you were in Thiruvarur Medical College as dean. I was very impressed with your administrative skills and all the other things, how we were able to handle that single-handedly, that big institution, when the faculty and all were coming from outside. So the administrative skills, the knowledge you have in the wide branches of anesthesiology and other aspects of life, and your skill in Tamil oration and things, these were all very, I don't know how to say the words. I was so impressed. And then we used to keep gossiping about you. Sir, appa DME our, sir, appa, that means when will sir become our DME? So that is the gossip going on in Chennai always. So fortunately or unfortunately, he is currently as a dean in Theni, which is a beautiful place. I would like to always visit that place for the wonderful waterfalls and the orchids and around the fruit plantations around there. So he gave a wonderful introduction about me having won the election and such things, but it is only due to some misunderstandings or something to say. But actually that could have been avoided, to be frank. Today's topics are all interesting clinical topics. I'm more impressed to do more clinical work and things rather than being more theoretical and going by the books. So because every practically anesthesiologist has to be a decider at that point of time, not merely your theory is going to help you in times of crisis. So that is the point. Your decision making at the critical crisis hour will decide your success. Hope you are audible to everyone. Yeah, that's the point I would like to convey. So all the 3 topics chosen today are very, very impressive and very good clinical topics. And they are supposed to be examiners' favorite for theory exam also. So I hope the presenters give an impressive show so that the audience will be benefited. I pass over the things to the speaker, first speaker.
Dr. Kunal.
Dr. Kunal, please take over.
A very good evening to one and all present over here. I, Dr. Kunal Modi from Gitanjali Medical College and Hospital, would be speaking on carbon monoxide poisoning today. But before we begin that, I am truly honored and humbled so that I was given this opportunity by the ISA Pudukkottai city branch. And I would also like to thank my entire department, my HOD ma'am, and my entire faculty for supporting me for this. And thank you so much for such an amazing introduction, ALM sir. To begin with, let's discuss about carbon monoxide poisoning. The goals.
Yes, doctor. Is there any time stipulated? Sir, any time stipulated for the speaker?
No, it is actually educative program, but we want the PG to close it by 10 minutes, another 30. But it is an educative program. We are not very strict with the timings, but we request you to close by 8 p.m. so that it will be convenient for everyone.
Yeah, yes, sir.
Sure.
Please proceed, Dr. Kunal.
Sure. Carbon monoxide poisoning. The goals for today's presentation are early recognition of carbon monoxide poisoning from the clinical presentation, to understand the pathophysiology of carbon monoxide poisoning and the approach to initial stabilization and evaluation of the patient, and the role of advanced therapeutic modalities like hyperbaric oxygen therapy and the recent advances that are introduced over here. Coming to the brief about properties of carbon monoxide. It is a colorless, odorless, non-irritant and tasteless gas produced by the incomplete combustion of carbon. And hence it is also a reason for a very common cause of the poisoning is that it is non-irritant, tasteless, so the people don't get to know whether they have been poisoned. So it is a silent killer. Normally, carbon monoxide is present in the atmosphere at a concentration of less than 10 ppm and becomes toxic at a level of 100 ppm in the atmosphere. Carbon monoxide has a 200 to 250 times higher binding capacity to hemoglobin than oxygen, and the fetal hemoglobin has an even higher binding capacity, resulting in severe fetal toxicity.
The screen is not seen, sir. Your slides are not seen.
Just a second, sir. I will share it again.
We don't see your slides. Yeah.
So is it visible
Now it's okay.
Okay,
Kunal.
sir. So the goals being early recognition to understand the pathophysiology and the approach to initial stabilization and evaluation, and the role of advanced therapeutic modalities like hyperbaric oxygen therapy and the recent advances for the same. The properties, as I've already said, are that it is a colorless, odorless, non-irritant and tasteless gas, and it is also one of the most common causes and acts as a silent poison because it is not detected by the person. Normally, carbon monoxide is present in the atmosphere at a concentration of less than 10 ppm and becomes toxic at a concentration higher than 100 ppm in the atmosphere. It has 200 to 250 times greater binding to Hb than oxygen, and the fetal hemoglobin has even higher binding capacity, resulting in severe fetal toxicity. Normally, carbon monoxide is produced endogenously in the body during the breakdown of heme, which results in blood levels of less than 1% in non-smoking healthy individuals. In smokers, it can be up to 5%. Now, coming on to the sources, there can be a car, a clogged chimney, corroded or disconnected water heaters, vent pipes, gas or wood burning fireplaces indoors, cracked or loose furnace exchangers, improperly installed kitchen range vents, operating a grill indoors, or portable kerosene and gas heaters. Coming on to the pathophysiology, before we begin with the pathophysiology, just a brief about the half-lives of carboxyhemoglobin. At room air, it has a half-life of 240 to 320 minutes. With 100% oxygen, it reduces to 70 to 80 minutes. And with methylene chloride exposure, which is usually found in paints and varnishes, it is up to 13 hours. Now, what carboxyhemoglobin level increase does is that it results in relative anemia and hypoxia. This ultimately shifts the ODC, that is the oxyhemoglobin dissociation curve, to the left, resulting in two things, that is impaired oxygen delivery to the tissues and decreased oxygen carrying capacity as well. Coming on to the cellular effects, it results in lactic acidosis and endothelial dysfunction and vasodilatation. Carbon monoxide inhibits the intracellular cytochrome oxidase and interferes with cellular respiration and ATP generation. This results in relative uncoupling of the oxidative phosphorylation, which causes anaerobic respiration and lactic acidosis. Release of guanyl acetylcyclase and nitric oxide by carbon monoxide result in endothelial dysfunction, vasodilation, which ultimately leads to hypotension. This relative hypoxia and hypotension can cause ischemic reperfusion injury, which is more prominent in the cardiac myocytes and neuronal tissue. Now, when it acts on the cardiac myocytes, it results in rhabdomyolysis, causing acute myocardial infarction, and on neuronal tissue, it can lead to neuronal cell death, which we'll further discuss when we discuss the CT images. Coming on to the clinical features, as you can see, I have tabulated this from the Winchester's clinical manual. The symptoms commonly being headache, dizziness, fatigue, or generalized weakness, nausea or vomiting, trouble thinking or confusion, loss of consciousness, dyspnea, and chest pain. And by the side are the percentage of patients which we can see. Now, it has a wide range of clinical manifestations and it involves almost all these systems. That is the entire central nervous system. There can be prolonged exposure to carbon monoxide resulting in chronic poisoning, which can lead to personality changes, depression, can be cardiovascular involvement, which can lead to tachycardia, fatigue, other ECG changes can be there. Pulmonary, gastrointestinal, ophthalmic, dermatological, which is the typical cherry red skin appearance can be there in this. And there can be muscular, hematological, and metabolic changes as well. Coming on to the investigation part, for blood, we can get routine CBC, blood sugar to rule out hypoglycemia or diabetic ketoacidosis. We can get VBGs and ABGs, carboxyhemoglobin blood levels. In the cardiac, we can get CPK-MB marker, troponin, brain natriuretic peptide, and an ECG. I have already mentioned the cutoff limits for the same in carbon monoxide poisoning. Radiological, we can get investigated things like CT brain, MRI brain, and chest X-ray. Other investigations include co-oximetry and not just simple pulse oximetry, because pulse oximetry, what it does is it uses only 2 wavelengths, so you don't get the actual readings, whereas co-oximetry uses up to 8 wavelengths, so you can differentiate between carboxyhemoglobin, methemoglobin, and all the other various aspects of the same. Spectrophotometry, breath analysis, mini mental status examination for psychiatric evaluation part of the same, and a urine pregnancy test in childbearing females, because that again it changes our treatment part of the same. Now these are the diagnostic study findings associated with carbon monoxide poisoning. That is, the carboxyhemoglobin levels will be raised, artificially elevated oxyhemoglobin saturation using pulse oximetry. There is an increase in the lactate, as we have already discussed. There is lactic acidosis. There is a typical increase in the anion gap metabolic acidosis. There will be an increase in the CPK because of rhabdomyolysis from the cardiac sources, increase in the troponins, and variable ECG findings, including STMI, ST changes, and T changes. Bilateral globus pallidus lesions can be seen on the MRI, and further changes can be seen on the ECG. These are the CT images. As you can see, they have been marked with the arrows. After 16 hours of injury, bilateral symmetrical low attenuation lesions can be seen in the globus pallidus and cerebellum regions of the brain. This is another CT scan image showing the lesion in the globus pallidus and hippocampus. As you can see, it has been marked by black arrows. Now, differential diagnosis can be something very basic or can be something really complicated, as carbon monoxide poisoning has a very variable and a wide range of clinical manifestations. That can be hypoglycemia and hypoxemia, can be a viral syndrome, or depression, can be another drug intoxication, associated cyanide poisoning, patients with mental status changes, a patient with an elevated anion gap metabolic acidosis, an unexplained lactic acidosis, or a comatose patient that has been removed from a fire scene should be assumed to have carbon monoxide poisoning until unless proven otherwise, even in the absence of cutaneous or airway burns. Coming on to the treatment portion, there are general measures that include immediate removal from the contaminated environment, safety of the patient, scene safety, and then there is resuscitation, airway breathing, and circulation. Our mainstay of treatment is the elimination of carbon monoxide from the body. This can be achieved by various methods like supplemental oxygen at a concentration of 1 FiO2, that is 100% oxygen, immediately and for at least 4 hours via masks, NRBM, ET tubes, and HFNO, CPAP, whatever it is available, and based on the severity of the case itself. We have to provide oxygen therapy until the carboxyhemoglobin levels reduce down to less than 10%. Early PEEP can prevent progressive atelectasis and improve oxygen diffusion. In general, carboxyhemoglobin levels fall rapidly to less than 10% within 30 minutes with 100% of oxygen delivery. We have to maintain 100% oxygen for additional 2 to 3 hours after it has reduced down to less than 10%. And anaerobic metabolism universally is seen with carboxyhemoglobin of levels more than 40%. So we have to monitor for the return of aerobic metabolism with normal serum bicarbonate levels as well. In patients with associated altered mental status, use of thiamine and dextrose and naloxone has been advised, and in cases of associated cyanide poisoning, use of hydroxycobalamin has been advised. Now, to initiate hyperbaric oxygen therapy as a treatment. So in this graph, you can see that the percentage of carboxyhemoglobin and the duration over which it is there. So basically, it shows that after giving 100% oxygen at normal pressures, that is normobaric, and hyperbaric oxygen with 100% and indoor air. So the green graph shows the indoor air treatment with 100% oxygen at normobaric levels is seen with the blue line, and with the red, we can see that 100% oxygen given through hyperbaric. So this drastically reduces the level of carboxyhemoglobin in minutes. Coming on to the management algorithm, on the left you can see these are the hyperbaric chambers. So basically, this entire algorithm shows us when the patient is supposed to be taken for hyperbaric oxygen therapy or not. Now, some of the indications for hyperbaric oxygen therapy are syncope, confusion or altered mental status, seizures, comatose, any patient with focal neurological deficit, pregnancy with a carboxyhemoglobin level of greater than 15%, or blood levels of more than 25% in a normal healthy individual, or evidence of acute myocardial ischemia. Now, before shifting the patient, he has to be clinically stabilized. That is, there has to be a secure airway, stable hemodynamics before shifting him to the HBOT chamber. Coming on to the complications of HBOT, these are pneumothorax, barotrauma to the ears, seizures from oxygen toxicity, and gas embolism. Now, there are special population which need to be considered for the same, that is children, are more susceptible due to the presence of fetal hemoglobin and their metabolic rate. Here, HBO has proven to be a good safety profile for the same. In elderly patients, high risk from poisoning, especially in seriously comorbid patients who are not very mobile, risk of coronary artery diseases, even at low levels of carboxyhemoglobin as low as 4 to 6% can cause ECG changes and myocardial ischemia. In pregnant patients, HBO therapy can be done if they meet the criteria or if there are signs of fetal distress. And in pregnancy, even the normobaric oxygen therapy has to be prolonged because there is slower elimination of carbon monoxide from the fetus. Now, coming on to the recent advances, recently they have said that the use of hydroxycobalamin and ascorbic acid can be done, as cyanide poisoning can be associated with carbon monoxide poisoning. Another thing is the use of cyclodextrin encapsulated porphyrin complexes. What this does is it is going to bind to the hemoglobin molecule and has a 100 times more higher affinity to hemoglobin than carbon monoxide. So this will basically replace it and eliminate the carbon monoxide. But these are currently at a stage where it has been experimenters have been done only in the rodents, and human trials are still pending. Another recent advance in the same is the use of modified globin proteins for the elimination of carbon monoxide. So thank you so much. I hope I have completed this within the time limit of 10 minutes.
Yes, Dr. Kunal, you've made a very elaborate presentation about the features, clinical features, the pathology, and all the aspects of clinical things and management about carbon monoxide poisoning, and touched upon the cyanide poisoning also. That's good of you. Any questions from the audience? So there is a saying in the West, like, when you are cherry red, you are indeed dead. What it means? It literally means carbon monoxide poisoning. So it was almost associated with the silent death.
Yes, sir, it is a silent
death. That is the thing going on in the West, especially in the closed environment where they have these barbecue things, the heaters, with wooden logs, and then the car garages, when they keep it on, there is a possibility of carbon monoxide poisoning. That is the commonest thing happening there. So it is one of the chemical asphyxiants. Actually, we deal with 3 chemical asphyxiants. One is the carbon monoxide, the other one is cyanide, and then you have this thing called sulfhemoglobinemia caused by hydrogen sulfide. So there is a subtle difference between these 3 things. Hope you people are all aware of it. For the sake of the audience, I would like to emphasize once again that it is a very simple concept. Carbon monoxide loves hemoglobin more than oxygen. So hemoglobin is just a carrier of oxygen. It takes oxygen from the alveoli, it delivers to the tissue level. So it's as simple as that. So there is a problem in loading. So instead of oxygen, this carbon monoxide will go and sit upon that. So at the tissue level, when it has to deliver oxygen, instead this carbon monoxide is sitting there, and this is the get down of the vehicle. So it is only stationed there. So loading is a problem as well as unloading is a problem. So that is why there is a tissue hypoxemia. So you must clearly understand the differences between carbon monoxide, cyanide, and hydrogen sulfide, methemoglobinemia. So to be precise, I would like to emphasize in all the 3 cases, you have PaO2 normal PaO2. So take a note of it. PaO2 is normal in all 3 cases: methemoglobin, cyanide poisoning, and carbon monoxide poisoning. Whereas what happens there? SaO2 is normal in cyanide poisoning, whereas SaO2 is reduced in methemoglobinemia and carbon monoxide poisoning. The oxygen binding is normal in cyanide. Again, cyanide is a very tricky situation. whereas it is shifted, the ODC curve, as you told, is shifted in the other two cases, carbon monoxide and methemoglobin. The complex IV, the cytochrome oxidase, the complex and the things, no, it is inhibited in cyanide and carbon monoxide, whereas it is normal in methemoglobin. So the treatment for methemoglobin, I hope you know, is methylene blue, whereas for cyanide, it is hydroxycobalamin, sodium thiosulfate, and things. And as you said, hyperbaric oxygen and simple oxygen therapy itself is enough for carbon monoxide with all the supportive care. So nice of you presenting this interesting clinical topic. Any question from the audience and the moderators? Anybody else? Sharing your clinical views.
Karthik,
Sir, we can take
discussion-
at the end of the talk.
discussion will be at the end.
Okay, sir. I
Sir,
thought the
good evening,
topic
sir.
can be discussed right away with the speaker. Okay, sir. I'll take your point, sir. May I call upon the next speaker to take over?
Yes, sir.
Dr. Nirdesh, I hope you're there. Yeah.
Yes, I am here.
Your topic is acute lung injury, right?
Yes, sir.
Yes, sir. Can you share your screen?
Yes, sir. I'm
The
doing
previous presenter screen is on the display. Can you open your screen and share it?
that. My PPT is visible?
It's just it's evolving. Some more time it takes. Probably the A1 team has to confirm. Yeah. Your screen is visible now. Yes, Doctor Nirdesh, please go on.
Okay, sir. First of all, good evening, everyone, and thank you for giving me opportunity to present the very interesting topic, acute lung injury or ARDS. I'm Dr. Nirdesh Thakur, EP in Ananta Medical Institute of Medical Sciences in Jaipur. I did MD anesthesia and FME in critical medicine. Now, I would like to start my topic. Just a case scenario: a 42-year-old female came with the history of smoking and complaint of severe breathlessness since 2 days and fever since 5 days with SpO2 60 on high flow mask with 12-liter oxygen flow, BP with 140/90, AVG showing PaCO2 of 42, immediately intubated and completely sedated and paralyzed with ventilative setting of tidal volume 420 ml, EP8. This respiratory rate 35 and FiO2 30. FiO2 100. Now question is, what is diagnosis and how to manage it? As we know, it's
Is it
Yeah,
PaO2 or PaCO2, Shashi?
sorry, it's a PaO2, sir.
PaO2, okay.
Yes, sir. It's not moving.
So the PaO2 is showing severe hypoxemia.
Yes, sir. My
With
slide is
oxygen, the saturation is very low, history of fever and breathlessness pointing to some respiratory
Yes.
illness. Okay.
yes, sir. Now, actually, the real term acute lung injury is obsolete now. We use ARDS, and I will let you know how we do this. Now, I will take this in this way. What is ARDS? Berlin versus AECC definition, risk factors, etiology, clinical course, pathophysiology, differential diagnosis, and management. History. Initial description in 1967 is given by Ashbob. New definition in 1994 by AECC, that is for ARDS or acute lung injuries, it should be acute. PF ratio, ALI and ARDS is defined by this PF ratio. Bilateral infiltrates on chest X-ray. PCWP, that is pulmonary capillary wedge pressure less than 18 mmHg and no heart failure. But this was not appropriate as pulmonary artery catheter insertion is very risky and very invasive procedure. So Berlin came with came with new definition in 2012, which includes it should be acute in onset and bilateral with bilateral pulmonary infiltrates, PaO2 and FiO2 ratio less than 300, that is ALI, PO2 and FiO2 less than 200 indicates ARDS. PCWP less than 18 mmHg or no evidence of left atrial hypertension or no clear evidence of heart failure. And SaO2 upon FiO2 less than 180. That is SaO2 less than 90% on 50% of oxygen in the absence of ABG. But this was not appropriate as again it was using PCWP. So now according to latest updated Berlin definition, the correct definition for ALI or ARDS is timing. It should be within 1 week of known clinical insult or new or worsening respiratory symptom. Chest imaging showing bilateral opacities not fully explained by effusion, lower lung collapse, or nodules. And what is the source of edema? Respiratory failure not fully explained by cardiac failure or fluid overload. Need objective assessment like echocardiography to exclude hydrostatic edema if no risk factor present. And oxygenation. I'm emphasizing of with P greater than 5 centimeter S2. It is classified as mild PO2 upon FiO2 between 200 to 300 mg, that is mild. With PO2 upon FiO2 100 to 200, that is moderate. And severe PO2 upon FiO2 less than 100 mm of Hg. Now, what are the risk factors? First, direct lung injury. That one example is pneumonia, aspiration of gastric contents, pulmonary contusions, inhalational injuries. That is very common in sulfur poisoning caused by phosgene gas or mustard gas used in World War, near drowning, and in indirect lung injury like sepsis is very commonly seen in ICU, non-thoracic trauma or hemorrhagic shock. Pancreatitis, again, it's very common. Major burn injuries, drug overdoses, transfusion of blood products, or even in the cardiopulmonary bypass. This is taken from NEGM. From 70. Now, condition that mimics ARDS is congestive cardiac failure, interstitial lung disease, connective tissue disorders, drug-induced lung disease, diffuse alveolar damage from vasculitis or Wood-Pasteur syndrome, cancer, endobronchial tuberculosis. Now, pathophysiology, the natural history of ARDS is marked by 3 phases. First is exudative, that is in first 7 days, then proliferative after 7 to 21 days, then fibrotic after 3 to 4 weeks. What happens actually is first insult, direct or indirect, which cause activation of inflammatory cells and mediators, which cause damage to alveolar capillary membrane, which increases permeability of alveolar capillary membrane, which causes influx of protein-rich edema fluid and inflammatory cell into air spaces, which also with dysfunction of surfactants as type 2 pneumocytes and type 1 pneumocytes are damaged in ARDS. That is very common. Now, for ARDS, when Ashbog took a biopsy of damaged lung, he saw the process was diffuse pulmonary process and generalized uniform injury to pulmonary microcirculation. It was autopsy running. In autopsy, lungs were heavy, areas of alveolar atelectasis, interstitial and alveolar hemorrhage, and edema, and dilated and congested capillaries. Now, factors causing hypoxia, first alveolar damage, capillary damage, leakage of edema fluid, inflammatory cellular infiltrate which accumulates there, ventricular perfusion mismatch, atelectasis, decreased thoracic compliance, increased dead space, and hypoxic vasoconstriction. Now, what is the management of ARDS? This is a table which I will explain in another slides. Now, what is the role of NIV? It's only used initially. It's a very brief rule. Its only class of indication is COPD or cardiac failure, but NIV we should only give for 1 to 2 hours trial for using NIV to avoid intubation. But if situation worsens, then we have to go for invasive ventilation. Now, this is how should we manage. I will discuss this in further slides. What is the major issues? First, we have to deal with lung protection. When hypoxia become critical and refractory, what are the salvages, therapies, and role of ECMO? Baby lung concept. This is very interesting concept. In ARDS, it behaves like a lung of a baby. ARDS result in significant reduction in the amount of normally aerated lung tissue. There is heterogeneous distribution. Unaerated segment will respond poorly. High pressure with low response. The baby lung was, that is, the salvage tissue was over descended by the higher tidal volume. That is very major concern, which further increments the injury. Now, what are the various trauma we can see during the management of ARDS? First is volume trauma, strain due to over distension of compliant alveoli leading to volume trauma. High inspiratory pressure, P-flat exactly, leading to barotrauma. Shear stress due to complete closure and reopening of non-compliant alveoli, that is atelectasis trauma. Release of inflammatory mediators from lung, that causing biotrauma. This all leads to a valide, that is ventilator associated lung injury. This is a diagram showing the various processes going on. This is the lung. We can see seeing in autopsy after ARDS. What are the objectives? Objectives are adequate ventilation of compliant alveoli without causing polytrauma and avoiding barotrauma. What are the strategies? Small tidal volume, that let's say 4 to 6 ml per kg with high respiratory rate. Yes, we can give permissive hypercapnia we should restrict, we can allow PaCO2 to be less than 80 mmHg. Important is limiting P-flat less than 30 centimeter of S2O, or using pressure control ventilation, or pressure regulatory volume control or autoflow if needed. Now, in lung protective ventilation, this is the airway pressure with volume. We have to remain in the safe zone, that is, we can see between this target tidal volume 6 ml to 6 ml per kg. Above this causes rise in P-flat pressure, again causing volume trauma or barotrauma, and extreme low pressure causes collapse of alveoli. So oxygenation will be hampered, so not adequately managed. So in the NEGM, it was published with ventilation with low tidal volume as compared with traditional tidal volumes for acute lung injury and the ARDS. So ARDS network trial, network 2000, it shows tidal volume less than 6 ml per kg with P-flat less than 30, PEEP as protocol given below, actual PEEP 8, result showing significant reduction in mortality and ventilator stay for the patients. As I mentioned above, lower duration of ventilation and lower incidence of non-lung organ failure days. So 6 ml per kg is the standard of, according to ARDS network, published as well as by Amato trial and in Cochrane database also by Petrucci and Lacovelli. Now, how to do that? First, we have to calculate the ideal body weight. See, it's not actual body weight. We have to calculate ideal body weight. The formula for males is 50 plus 2.3 into height in inches minus 60, and for females is 45.5 plus 2.3 into height into inches minus 60. It's easy. we can easily do by using inch tape. Then set initial tidal volume at 8 ml per kg of ideal body weight and add PEEP of 5 centimeter of SO and select lowest FiO2 to achieve SpO2 of 88 to 95% and reduce tidal volume by 1 ml per kg every 2 hours until tidal volume of 6 ml per kg was achieved. Second stage, when tidal volume is 6 ml per kg, we should measure plateau pressure. And how we measure plateau pressure? We fully paralyze and sedate the patient, then take in volume control mode, and during stop of inspiratory flow, we calculate P plateau is shown. If P plateau is greater than 30 centimeters to decrease V tidal volume by 1 ml per kg, increment until P plat is achieved less than 30 centimeter of SO. Now, third stage, do AVG for look for respiratory acidosis. If pH is between 7.15 to 7.13, increase respiratory rate until pH is achieved greater than 7.3 or respiratory rate is greater than 35 breath per minute. If pH is less than 7.15, increase respiratory rate to 35 breaths per minute. If pH is still less than 7.15, increase tidal volume to 1 ml per kg, increment until pH is greater than 7.15. Right. Optimum goals are, as I already mentioned, tidal volume 6 ml per kg, we plat less than 30 centimeter, target SpO2 not 100%, it's 88 to 95%, pH 77.3 to 7.45, or PaO2 55 to 80 mm of Hg. Now, there is no evidence of benefit of low tidal volume beside ARDS or ALI. Hypercapnia, acidosis, hypoxemia, these are the significant drawbacks of using tidal volume. Hypercapnic acidosis, hypoxemia, ventilator asynchrony. Patient with higher baseline with permanent compliance had increase in mortality when receiving a lower tidal volume. This is according to ARMA trial done in 2005. Now, as I discussed, if P plat is between 25 to 30, then tidal volume is 6 to 8 ml per kg. If P plat is greater than 30 centimeters to, then it should be tidal volume should be 6 ml per kg. What are the consequences of lung protective ventilation? First is hypocarbia. Yes, ventilator asynchrony. To prevent ventilator asynchrony, we have to use more sedation, more paralysis, and as we are decreasing tidal volume, hypoxemia can also occur. So these are the drawbacks. What are the rescue therapies? The first time rescue therapies are PEEP, recruitment maneuvers, pressure controlled inverse ratio ventilation, neuromuscular blockade, very, very important, prone ventilation, and inhaled nitric oxide. Now, in ARDS, the transpulmonary pressure, that is alveolar minus P plat, is decreased in dependent areas, which leads to over distension of alveoli in non-dependent area. Goal is to increase transpulmonary pressure in dependent areas, that is by increasing PEEP or doing prone position. Actually, prone position is a method of recruiting a lung. No, it's nothing else. So, at this diagram, just want to say the lung is, want to make understand people, the lung is pear-shaped structure. The density of alveoli is more, is at the dorsal end, and even perfusion is more at dorsal end. So we have, by proning, we actually increase oxygenation in that part of area, or even this improves our oxygenation. This and by other ways also. I will discuss it later. So how to set PEEP? We should not cram it by seeing ARDS net trial. First is we should look for point of maximal alveolar recruitment. First method is incremental PEEP method. The point of best compliance at increasing levels of PEEP, you should keep increasing PEEP till change in PEEP lat is seen, less than or equal to change in PEEP. And same as decremental PEEP, start at high PEEP, keep decreasing the PEEP by checking the compliance PEEP at which the compliance are decreasing. Just keep PEEP just about that. This is the diagram which I explained already. So in the volume pressure curve, we had to keep the things between the lower inflection point and over upper inflection point. So beaking should not be there. We should not be in the beak zone or lower zone also. So this is the alveolar trial showing high versus low PEEP. So there is no major outcome were obtained using high PEEP or low PEEP. Actually, we have to check for compliance. Where the compliance is best, we should keep that. You should not. This is mug up the rule. High PEEP ARDS means high PEEP. This is not done. You should seek compliance or PEEP flat. So this is the recruitment maneuvers. When we use recruitment maneuvers, it is only seen, it is obtained that the open lung surgery did appear to improve secondary endpoints related to hypoxemia and use of rescue therapies. So only in the moderate or severe ARDS, it is beneficial, not in mild ARDS. Same results are obtained in alveoli, LOVES, and EXPRESS trials. So in normal pressure, in ARDS patient, better survival are seen with in ARDS person by using rescue therapies or high PEEP model. And with less rescue therapies, better outcome are obtained in normal lung patient. And because with recruitment maneuver, we may face complication like pneumothorax or decrease in ventricular return, and which cause eventually hypotension. So how do we recruit? We have to, it's just opening up closed and non-compliant alveoli. Recruitment potential is highest in early phase and mainly in extrapulmonary ARDS. This is taken from multiple articles like published in Anesthesia 2002, Current Opinion in Critical Care 2003, and Critical Care Medicine 2004. Now, how do we recruit? First method is use paralyzed patient and sedate patient properly, then put the patient on CPAP mode, set pressure of 30 to 40 centimeters of H2O for 30 to 40 seconds, then stop. And or second method is series for large tidal volume, 20 to 15 ml of per kg for 1 to 2 minutes. Third method is series of breaths with pressure controlled volume for 40 to 50 centimeters H2O for 1 to 2 minutes. And CT scan method or USG method, where we can actually see doing USG probe or in CT scan. CT scan is very difficult to do practically, but yeah, we can use USG. I use USG while recruitment. So what should we ensure before doing recruitment maneuver? First and foremost thing is hemodynamic stabilization. Patient should be euvolemic, not hyper, not hypo. Check X-ray for pneumothorax or pneumomediastinum. Check ABG like PaO2, PaCO2. check compliance, ensure sedation and neuromuscular blockade. Otherwise, you will gonna harm patient by doing pneumothorax. That is a big problem. So it helps conclude for recruitment manual. The conclusion is the adult patient with ALI receiving recruitment manual experience a significant increase in oxygenation, but with few serious adverse events. So it should be done very carefully and with high vigilance, with experience also, which gradually earn with experience. So this is the lung before CT scan of lung before recruitment and after recruitment. Now, role of neuromuscular blockers in acute respiratory distress, that is ACURACIS trial, which shows use of cis-atracurium initial in the 48 hour decreases mortality, increases more ventilator free time, less other organ failure, less muscular weakness was similar, may work by facilitating non-productive ventilation. So, cis-atracurium paralysis improves survival in early ARDS. Now, prone position, that is very, very, very important. It improves oxygenation, it allows ventilation with lower tidal volume, pressure, and FiO2. It enhances the drainage of secretions. It increases rise in PO2 sustained after return to supine. So what are the problems? Yeah, every therapy has benefits and side effects. The side effects are pressure ulcers and facial edema. Lines and tubes may detach or expel out. Yeah, in condition like CPR, we have to again make patient supine. That is very difficult. And according to Gattinoni, very famous person who introduced proning in ARDS, 20% patient are non-responders to proning. But proning really worked during the COVID days in my experience, even before that in swine flu also. So how it works? It basically changes the regional compliance. It also affects the regional blood flow and ventilation. It ensures adequate ventilation perfusion ratio. It relieves compression of the lung by heart and lung by the heart and the mediastinal structure. It decreases the pressure of heart and mediastinal structure. So yes, the prone not by antibiotics, not by ventilator, only proning strategy decreases the mortality. And the ProSeva trial, that is the landmark trial which showed us, this done by Gattinoni, I personally met him. It decreases mortality by 40%. As I already told you, lung is like a sponge. It's more denser in the lower end. So by changing the position in prone, we allow that alveoli to sufficiently distend and enhance drainage of secretions and release the pressure of mediastinal structure, and which eventually improves V2 match. So this is the ProSeva trial I told you. So what it shows us the optimal timing. It should be done early, as soon as possible, within 6 hours, and prone position should be restricted to 16 hours, and it should be seized when PF ratio is greater than 150 mmHg with PEEP less than 10 centimeter SU and FiO2 less than 60% for greater than 4 hours after last prone session, or decrease PF ratio in 2 consecutive prone session of 20% related to the supine complication. Complication during prone session leading to its interruption. Mechanical ventilation was modeled after the low tidal volume as per ARDS net protocol. So this is a ProSeva trial, as I already told you. So reason for ProSeva's success is early intervention, that is within 36 hours of ARDS, most appropriate patient using a 12 to 24 hours stabilization period, significant proportion of time spent pruning, that is 73% versus closer to 30% in other trials. That is why ProSeva told us, so do it in that way only. Now, advanced modes that can use, the first is APRV is just like a method of inverse ratio ventilation. Here we, as shown in diagram, it is like a protective lung ventilation strategy. It's a type of movement mode. It's a bilevel ventilation special release valve for sudden release in pressure to rapidly reduce the FRC and allow for ventilation. APRE always imply inverse I to E ratio, that is inspiratory to expiratory ratio. Now, how to set it? Inspiratory pressure set between 20 to 30 centimeter of STO2. Expiratory set between 0 to 2 to 3 centimeter STO2. Majority of the time, that is inspiratory time set between 3 to 5 seconds. Expiratory time set only for 0.5 to 1 second. Longer expiratory time leads to de-recruitment, which we do not want. I to E ratio set between 4:1 to 10:1. Set rate never exceed 20 per minute. This is a way. So conclusion is the APRE may offer potential clinical advantage for ventilator management of acute lung injury or ARDS patient, may be considered as an alternative to open lung approach to mechanical ventilation. Whether it's decreases mortality or no is still research is needed to be done. Now, consider APRE when there is by same as ARDS, as I told you earlier, the criteria for ARDS. Now, second mode is high frequency oscillatory ventilation. This is just simple thing. It oscillates the lung around a constant mean airway pressure, that is ultra protection 1 to 2 ml of per kg tidal volume is set. Constant mean area pressure of alveoli during inspiration and expiration, established for use in cases of neonatal ARDS. During control mode ventilation, there are swings between the zones of injury from inspiration to expiration. During HFOV, the entire cycle operates in the safe window and avoids the injury zone. But oscillate trials showed no significant benefit, so it's not used frequently nowadays. Now, the newer concept is driving pressure. It is nothing but very simple. We have to check driving pressure. How can we check it? By simply calculating P plateau pressure minus P upon tidal volume. It should be less than 15 centimeter of S2. It is shown, it is as it is published in NEGM, it significantly decreases mortality. But how we do it is by pruning or decreasing tidal volume or increasing P. Okay. So inhaled nitric oxide again is I use it personally, but not a significant benefit was found during my use or my experience. Even future studies are going on right now, but it started its use. Theoretically, is improved oxygen, safe to use, benefit when combined with open lung ventilatory strategies. Now, ECMO. It is used for the most severe, potentially reversible acute respiratory failure. It replaces pulmonary function, allows ultra protective mechanical ventilation. It allows lung to rest and to promote lung healing. Here we just put patient on ECMO machine, decrease tidal volume to 1 to 2 ml of per kg, and set minimum FiO2 as whole the function of lung is carried by ECMO machine. So it gives time to lung to recover from the injury. So what are indication? Refractory hypoxemia, that is PF to less than 100 despite 6 hours of ARDS appropriate ventilation. Refractory acidemia, that is pH less than 7.15 from ARDS. Excessively high inspiratory platelet pressure caused by ARDS. For this, we have to calculate Murray score, that is average score for all 4 parameters. 4 parameters are PF ratio, chest X-ray, PEEP, and compliance. So one Caesar trial showed that it ECMO significantly if Murray score is greater than 3 or pH is less than 7.20. It increases survival of patient. It decreases mortality and ICU. It also decreases ICU stay for patient. But it should fit in the Murray score. Its Murray score should be greater than 3 or pH should be less than 10.2. So conclusion of Caesar trial was we recommend transferring of adult patient with severe or potentially reversible respiratory failure whose Murray score is greater than 3 or pH less than 7.2. ECMO-based management protocol to significantly improve survival without severe disability. This is very good result that is published in Caesar trial. Okay. This is how we put 19 French cannula in right IJV and 22 French cannula in right femoral vein, and this is the ECMO machine. I'm not going to do in details of this. So method is first is lung protecting ventilation, optimizing PEEP, then proning the patient. If still not work, then use ECMO. Now, one few things also. The fact trials shows us that the dry lungs are happy lungs. So it means patient should be kept in the negative balance during managing ARDS. We used to have CRRT machine to maintain the euvolemia in the patient or negative balance in the patient suffering from ARDS. So this is the collision fact trial. On role of steroids, Madhuri trial shows there is no significant mortality benefit. Only in its use is if patient is in septic shock, it can be used, steroids can be used, or it should be in the early phase, not in the late or fibrotic stage. So routine administration of corticosteroid in ARDS cannot be recommended and their use seems harmful when started 2 weeks later. So these are the summary of all trials which are used: Oscar, Oscillate, LungSafe, Proseva, Eolia, and Caesar. So conclusion is low tidal volume ventilation, treat underlying illness by using antibiotics, titrated PEEP, recruitment maneuver if required, prone positioning, keep measuring driving pressure is very important. Look for ECMO if center is there, ECMO center is there, and if fitting in the criteria by using Murray score. Keep lung dry and give lungs time to recover. Thank you so much.
Thank you, Dr. Nirdesh. It was a very elaborate presentation, and you're sharing your experience also with us. You elaborated about the ALA and ARDS criteria, the PF ratio, and all those things. To summarize, I would like to say ALA consists of 3 primary things. One is acute in onset. that is 1 to 6 days. Hypoxemia is there. Bilateral infiltrates, chest infiltrates seen on chest X-ray or CT scan. No LA hypertension. These three criteria must fit in to diagnose ALI and ARDS. Okay. And then a few words about trolley, because that is also commonly encountered when you involved in a trauma setup, or when you have a major surgical setup in orthopedic or something where you have to transfer sort of blood and blood products. Trolley, I don't want to talk about the theory, but I would like to emphasize upon some clinical aspects of trolley, wherein you have a confusion in diagnosing trolley, because diagnosis mostly by exclusion. One condition which will mimic trolley is anaphylaxis to blood transfusion. How do you differentiate anaphylaxis to blood transfusion per se and the trolley? So both the presentations are similar. Only difference is there is no fever in anaphylaxis, and there is frank pulmonary edema. So also you can encounter a transfusion-related septicemia, acute septicemia. There you can differentiate from trolley based on the symptoms. There is no respiratory symptom in transfusion-related sepsis, whereas trolley, acute lung injury, will have respiratory symptoms of tachypnea, cyanosis, and all these things. Okay. So also another condition which will mimic this is the what is it? TACO, transfusion associated cardiopulmonary cardiac overload. TACO, it is called TACO. So when you have a cardiac overload, it also mimics this condition, but it responds very well to diuretics. So based on that, you can say. And also there is a subtle difference in BP, blood pressure. So basal blood pressure monitoring itself will show trolley will have a hypotension scenario, whereas this condition of circulatory overload will have a transient hypertension condition. As I said, there is a cardiac involvement in this, whereas the echocardiogram will show no cardiac involvement in the other setup, trolley. So for the sake of audience, I wanted to brush up with the TACO and trolley also here. And he has elaborated about the Murray scoring system, the oxygenation index, and all these things. These are all very important clinical points when you manage a ALI and ARDS patient in the ICU setup. So nice of you, doctor, to brief about your clinical experience with us. Next, Dr. Shashi Thakur will take over for the management of uncontrolled hypertensive patient presenting with the gastric perforation in the ER room. Yes, doctor, please proceed.
Good evening, everyone. Thank you, ISA Udaipur, and thank you, ISA Pudukkottai branch, for giving me this opportunity. I'm sharing my screen. Yeah, is it visible, sir?
Yes, yes, your slides are visible.
Yes, sir. So my topic is anesthetic management in patient with uncontrolled hypertension with gastric perforation for emergency laparotomy. Actually, this is a PG question, PG exam question. So we will discuss it. It's a very interesting topic, and this topic includes 3 topics actually. So we'll discuss it in 3 headings. First is hypertension, then gastric perforation, and then we'll discuss about emergency laparotomy and anesthetic management. So hypertension. It is the most common medical diagnosis which results in end organ damage in the vasculature, heart, brain, kidneys, and eyes. It is associated with more of the cardiovascular disease deaths than any other modifiable diseases. Severe perioperative hypertension may result in the excessive surgical bleeding, myocardial ischemia, infarction, congestive heart failure. That's why hypertension is a very important topic. There are lots and lots of guidelines about hypertension, like ACC AHA guidelines, International Society of Global Hypertension guidelines, JNC 8 guidelines. But I have taken NICE guidelines because these are the most updated and most widespread. So they have defined diagnostic threshold for hypertension to be 140/90 on clinic blood pressure. But the gold standard is ambulatory blood pressure monitoring, but this is not suitable for everyone. So home blood pressure monitoring is offered as an alternative. The diagnostic threshold for ABPM or HBPM is 135/85. For home blood pressure monitoring, patients should be advised to take at least 2 recordings, 1 minute apart, twice a day for 4 to 7 days. According to NICE guidelines, 2019 update, they have defined 3 stages of hypertension. So we will be taking clinic blood pressure here because in OT, we encounter only the clinic blood pressure. So stage 1 is 140 by 19 to 159 by 99. Stage 2 is 150 by 100 to 179 by 119. And stage 3 is more than 180 by 120. So why hypertension is important in surgical patients? Because exaggerated hypotension occurs after induction of anesthesia. It causes excessive hypertensive response to stresses like laryngoscopy, intubation, surgical incision, intubation. They are more prone to hypertensive responses post-operatively also. Hypertensive episodes are often associated with arrhythmias, MI. They even can cause cerebrovascular accident. And even when there is severe perioperative hypertension, that is more than 20% of the baseline, it can cause bleeding from the vascular suture line, cerebrovascular hemorrhage, myocardial ischemia, and mortality is as high as 50%. So how to evaluate about hypertension? We have to ask history. The most importantly, we have to answer 3 questions. First of all, hypertension is primary or secondary? Whether it is there is previous history of hypertension, patient is on any medications of hypertension, or this hypertension is because of pain, because of abdominal distension, because of abdominal rigidity, or it is a secondary hypertension because of some secondary causes like pheochromocytoma or vascular hypertension. So we have to evaluate hypertension in all these settings. Question we have to answer is the hypertension severe? Is it more than 180 by 110? It is or it is hypertensive crisis. We'll discuss this later. Third question we have to ask is, are any target organs involved? So how to evaluate involvement of the target organs? So what are the target organs? Hypertension can affect all the vascular organs of the body like brain, heart, kidney, eyes, peripheral vascular system, ENT. So it can lead to all these complications, like in brain, it can cause CVA, hypertensive encephalopathy, impaired cognition. And we have to ask the history of unconsciousness, headache, dizziness, seizure, confusion. And if time allows, we have to undergo CT scan or fundoscopy to evaluate the end organ dysfunction of the brain. So similarly, in heart, it can cause LVH, heart failure, CAD, diastolic dysfunction. So we need to ask the history of breathlessness, orthopnea, fatigue, palpitations, and we have to undergo ECG and echo. In eyes, it can cause retinopathy and patient may complain of decreased vision. So we have to evaluate fundoscopy, fundus examination, if time allows. In kidney, it can cause CKD, diabetic nephropathy, glomerular injury. So we have to ask the history of swelling of face, decreased urine output, nocturia, hematuria, and investigation we need to do urine albumin, serum creatinine, GFR. Similarly, it can cause peripheral vascular disease, nasal bleeding, etc. So we have to ask all these signs, evaluate signs and symptoms, and we have to get these investigations done. What is hypertensive crisis? According to AHA guidelines, BP more than 180 by 110 constitutes a hypertensive crisis. But it is defined into 2 headings, hypertensive emergencies and hypertensive urgency. What is hypertensive emergencies? Severe hypertension associated with the evidence of end organ damage is called as hypertensive emergencies. And when there is no end organ damage, then it is called as hypertensive urgency. So what to do when patient comes for elective surgery? Are there fixed BP targets? No. BP targets are individualized based on the age, type, and urgency of surgery and end organ damage. But still, Association of Anesthetists and British Hypertension Society guidelines, they have advised that patients whose blood pressure is less than 160 by 100, that is grade 1 hypertension, they may proceed for elective surgery without delaying for further investigations or treatment. Patients with grade 2 hypertension can also proceed with surgery, but they have to be evaluated by general practitioner and should be started on treatment. But patient is grade 3 hypertension, more than 180 by 110 millimeter of mercury. So guidelines suggest elective surgery should be postponed and should be referred to the general practitioner for optimization, which even can take minimum of 4 to 6 weeks of treatment. But if diastolic more than 110, it's itself an independent risk factor for cardiovascular complication and should be evaluated by the general practitioner. This slide is just to show how the treatment is started in patient on OPD basis. like first of all, ACE inhibitors are started, and in patient without diabetes, calcium channel blockers are started. Then they are added diuretics, and then all three combinations are used. And NICE guidelines have defined the target BP targets. For less than 80 years, they have defined the target of less than 140/90. And for more than 80 years, they have defined treatment targets to be 150/90 millimeters of mercury. So this is important for us, which drug should be continued and which should be stopped. If patient is already taking ACE inhibitors, so ARBs, they should be held 24 hours preoperatively because there is chance of intraoperative hypotension. But they should be restarted within 48 hours after operation. As a diuretics and calcium channel blockers can be continued, loop diuretics should be considered as per patient, and beta blockers should be continued when prescribed for congestive heart failure or MI, but they do not be started immediately for risk reduction. So what to do when patient presents for emergency surgery, like in this case, like what is the topic of our discussion? In that case, we have to proceed with surgery. We don't have much time to optimize patient. So in that case, at least a recent ECG and echocardiography should be reviewed, and STAT ECG should be done. And if available, point of care transthoracic echocardiogram should be done to assess the cardiac function rapidly. If it suggests significant pathology, a formal echocardiography can be performed and interpreted by cardiologists, but still it is done only if time allows. If surgery is of very emergent nature, then it's better to put an arterial line and do the careful monitoring of BP and start the pharmacological therapies as soon as possible, and have the critical care provision and treatment to be continued in ICU. What are the goals of anesthesia in patient with hypertension? Mean arterial pressure should be maintained between 65 to 70 so that to maintain the organ perfusion. Intraoperative systolic blood pressure should not be allowed to lower than 80% of the baseline, because in hypertensive patient, the autoregulation is reset. So if we allow it to decrease more than 20%, then even 130/80, we will be hypotension for them. So it can impair organ perfusion. So it should not be allowed more than 20% to be lowered. In hypertensive emergencies, BP should be reduced gradually from 10 to 15% to 20% controlled fashion within first hour, with continued decrease over the next 2 to 6 hours as tolerated by the patient. Exception is aortic dissection. In that case, more rapid reduction is advised. And patients of poorly controlled blood pressure, they also have diastolic dysfunction. So it is important to prevent tachycardia, and beta blockers are appropriate for that. So our next target is to maintain normal sinus rhythm. And most patients, they may develop atrial fibrillation. So in that case, rapid cardioversion should be available and rate control should be done, for which beta blockers and amiodarone are useful. These are the drugs for the perioperative management of hypertensive emergencies: esmolol, labetalol, clavitipin, nicardipine, nitroprusside, nitroglycerin, clonidine, urapidil, enariprilate. All these are drugs, and these are the doses at which they are started. So in which case, which drug to be given? So these are the clinical situations in which variable drug of choices are there. For example, if there is severe acute hypertension, then patient can be started on sodium nitroprusside. If patient presents with hypertension with ischemia, so the drug of choice will be nitroglycerin. In case patient presents with hypertension plus tachycardia and ischemia, so drug of choice will be beta blocker and alpha and beta blocker, for example, labetalol. If patient presents hypertension with heart failure, in that case, ACE inhibitors with inodilator, for example, combination of ACE inhibitors plus dobutamine can be used. If patient has hypertension without cardiac complications, then vasodilators can be used, for example, hydralazine, phentolamine, nifedipine, nicardipine. If hypertension is caused by pheochromocytoma, then vasodilators and alpha beta blockers can be used, for example, phentolamine, labetalol, doxazosine, etc. Now, coming to our second topic, gastric perforation. As we all know, perforated peptic ulcer is an important differential diagnosis in patients presenting with acute abdomen. Most of them are in duodenum, 67%. Only 17% of the gastric ulcers present with gastric perforation. Only 17% are there with gastric ulcers. And sometimes specific diagnosis is made at laparotomy. So presentation of gastric perforation is sudden onset severe epigastric pain and peritonism. That is a board-like abdominal rigidity caused by the spasm of recti muscles and sepsis. What is the etiology of gastric perforation? It may be spontaneous or traumatic. Spontaneous is mostly because of peptic ulceration, but it can also be due to perforated carcinoma, gastric valvulus, perforated hernia, and it can be due to trauma like surgery, endoscopy, VP shunt. But majority is from the spontaneous perforation due to the peptic ulcer disease. Two main factors implicated are the H. pylori and NSAIDs, and incidence is 1.5 to 3%. Lifetime prevalence of perforation is 5%, and mortality can be as high as up to 25%. Benign gastric ulcers occur in elderly and on the lesser curvature. And if we should have an idea if ulcers are on the greater curve, they are more commonly malignant. What is the pathophysiology in patients requiring emergency laparotomy in gastric perforation? First of all, peptic ulcer perforation leads to spillage of the acidic gastric contents into the peritoneal cavity. So it leads to severe chemical peritonitis. And when food leaks into the abdominal cavity, it leads to inflammatory reaction and numerous pockets of infection and abscess are formed. And later on, patient may develop sepsis and multi-organ failure. So all these things we have to ask in history and examination. The history of abdominal or chest pain and all the causes of the perforated peptic ulcer should be ruled out, like prior instrumentation, prior trauma, prior surgery, malignancy, ingestion of foreign bodies, medications, NSAIDs, glucocorticoids, etc. We should ask history of signs and symptoms like vomiting, refusal to feed, abdominal distension, decreased activity. And on examination, we should examine vital signs because most of the patients have tachycardia, tachypnea, fever, and abdominal tenderness. And thorough examination of abdomen and bowel sounds absent. So what are the anesthetic challenges in gastric perforation with hypertension? That is the topic of this presentation. Water and electrolyte derangement. Patient may have hypovolemia, hyponatremia, hypokalemia because of excessive vomiting. And later on, patient may develop hyperkalemia when kidneys are involved. So we need to do ABG to find out what electrolyte derangement patient has. Patient can have acid-base disturbance, like initially due to vomiting. Patient may have metabolic alkalosis, and later on, when patient has decreased intake, hypovolemia, later on patient can develop metabolic acidosis. Then patient can have excessive blood loss because this is a major surgery, major laparotomy. So excessive blood loss can be there. Patient can land up in sepsis. He can have multi-organ dysfunction. Pain is a major challenge in this type of patient because the incision will be larger. And in this particular patient, we have hypertension, which can cause hemodynamic instability and end organ dysfunction. So World Society of Emergency Surgery guidelines have provided some resuscitation targets for perforated and bleeding peptic ulcers. What are those? First of all, we know that perforated peptic ulcer is a medical and surgical emergency. In that unstable patients, we should have targets of mean arterial pressure to be more than 65, as I already told. Urine output should be maintained more than 0.5 ml per kg per hour and lactate normalization. So they suggest to use hemodynamic monitoring, and hemoglobin should be maintained more than 7 because it is a bleeding ulcer and any coagulopathy should be corrected. A study done by the Singapore team of anesthesiologists have defined emergency laparotomy pathway because they have done this study and they found that it decreased 30 days morbidity and mortality. What is that emergency laparotomy pathway? It has some flow chart which defines timeline. When patient comes to us, first of all, we should assess early warning score within 30 minutes of admission, followed by arterial lactate measurement and antibiotics within 1 hour of admission of suspected sepsis. Then general surgical review should be done within 2 hours of referral, followed by POSSUM score assessment, and surgery within 6 hours should be done. This flow chart shows the same. I will elaborate it in detail. So all these things I have already mentioned. Now we'll discuss in detail about preoperative preparation. First of all, early identification of physiological derangement and intervention. We should rapidly assess the physiological derangement by early warning score, and early resuscitation and correction of the physiological derangement should be done. What is early warning score? It's a simple score consisting of 6 parameters usually seen in that patient: heart rate, BP, respiratory rate, CNS, temperature, and urine output. Whenever studies indicate score is more than 3, patient requires urgent attention. So it identifies a high-risk patient, need of critical care admission, and it also predicts the mortality following emergency surgery. Secondly, we have to see, screen, and monitor for the sepsis and accompanying physiological derangements. So any validated sepsis score can be used to assess whether it is sepsis or not. For example, SOFA score can be used, and treatment should begin on the lines of surviving sepsis algorithm. Prompt antibiotic administration should be done within 1 hour, and monitoring of the lactate as a marker of risk and monitoring of response to resuscitation. For example, if lactate is in decreasing order, so our resuscitation is on correct lines. Then early imaging, surgery, and source control of sepsis. All patients with sepsis shock should receive source control within 3 hours, and those with sepsis without septic shock should have source control within 6 hours. Perform CT scan with contrast as soon as possible, but it should not cause delay in surgery. We should also do risk assessment and post-operative planning. We can use POSSUM score, which is the most widely accepted score, to assess the post-operative outcomes. As the name suggests, it is a physiological operative score for enumeration of mortality. So it consists of 12 physiological parameters and operative parameters. It looks cumbersome, but it is available as online calculator and with a smartphone app for areas with limited internet access. So you can just simply use it by putting the values on an online calculator, and it will give you prediction of the mortality and how much patient needs, how much is the risk of critical care admission, and how much is the morbidity and mortality. Reversal of antithrombotic medication. It's a very important thing. If patient is on any anticoagulant medications and major surgery is planned, it should be reversed. And if patient is taking antiplatelet therapy, consider platelet transfusion in that patient. But you should also know the indication of antiplatelet therapy, anticoagulant therapy, and the benefit ratio should be weighed according to the condition of the patient. We should also assess venous thromboembolism risk. If patient is a risk for venous thromboembolism because he will be lie on bed for longer time. So at least mechanical prophylaxis should be used for this patient, and reassessment should be on the daily basis post-operative. Pre-medication. Sedative pre-medication is obsolete now. It should be avoided, especially in this case, to avoid the risk of microaspiration, hypoventilation, and delirium. But analgesia should be used, and multimodal opioid-sparing analgesia is better, so to minimize the side effects. Preoperative glucose and electrolyte management should be done because both hyperglycemia and hypoglycemia are risk factors for adverse outcomes. Preoperatively, glucose levels should be maintained at 144 to 180 milligram per deciliter. And variable rate or sliding scale insulin can be used to maintain blood glucose in this range. And most of the patients may have hypokalemia, hypomagnesemia. So correction of electrolyte should be done by IV route. And it should not delay patient taking to the OT because it can be started even in the OT. Preoperative nasogastric tube insertion, it should be considered on the individual basis, assessing for the risk of aspiration and gastric distension depending on pathology and various patient factors. Now, patient and family education and shared decision making. It is very important because we take such patients as high risk cases, and we have to explain the about this high risk. What is the high risk to family? How we already have evaluated POSSUM score and early warning score, and we have already find out the percentage of how much high risk this patient is. So, in appropriate words and in writing, we should tell the patient and family about the high risk. Counseling should be done. What are our treatment escalation plans? We are planning to do send patient in critical care. All this should be documented. Coming to preoperative investigations, These are mainly aimed to find out the target organ damage. The most important investigation we should have is CBC, creatinine electrolytes, coagulation profile, ECG, and ABG. ABG is very important, including lactate, because lactate is marker of risk and in monitoring of response to resuscitation, and even in the absence of. What other investigation should be done? Blood grouping, LFT, amylase, glucose, urine analysis, CRP, HCG for women, only if time allows for all these. Mostly patients land up in sepsis. So what should be the goal of anesthesia in surgical sepsis? 3 key aspects to be covered. First of all, administration of antibiotics within 1 hour, because it has been shown to reduce mortality in septic shock. Second, prevention of the organ failure by hemodynamic resuscitation. Preoperative resuscitation with fluids in volume up to 30 ml per kg, aiming for the mean arterial pressure of more than 65. But in our case, patient is hypertensive. So we have to give fluid judiciously with hemodynamic monitoring, because patient may have LVH, patient can be in heart failure. So judicious use of fluid should be done. And third is source control by the surgical or radiological intervention. Coming to intraoperative management, induction. Most of the patients are full stomach. They are assumed to be full stomach. So rapid sequence induction is preferred. And because patient is already hypertensive, there is risk of hypotension after induction. So what should be the measure to avoid hypotension at induction of anesthesia? We can use large doses of short-acting opioids like fentanyl, lalfentanyl to reduce the dose of thiopentol or propofol. We can use ketamine or etomidate as IV induction agent. We should have vasopressors prepared before induction, and we can apply it after induction to maintain arterial blood pressure more than 65. And use of rocuronium instead of choline, because choline has so many side effects. We should also blend the stress response to laryngoscopy and intubation, because in hypertensive patients, there are more hypertensive response to laryngoscopy and intubation. So we can use IV xylocard, esmolol, fentanyl. And if indwelling nasogastric tube is present, it should be suction. Coming to maintenance of anesthesia, it can be done with volatile agent or total intravenous anesthesia, depending on clinician's preference. And patient with underlying organ dysfunction need careful consideration. For example, patient may have renal failure, liver failure. So it may alter metabolism. We have to decrease the doses of anesthesia or decrease the doses of muscle relaxants. Coming to fluid and hemodynamic support. What should be the measures to guide IV fluid therapy? How much fluid should be given? What fluid should be given? We'll discuss now. Hemodynamic features should be used to guide the fluid therapy. For example, heart rate, BP, CVP, and we already have done ABG. So lactate is the greatest marker of organ perfusion. An arterial catheter is strongly advised. In hypertensive patients with sepsis, it should be sited before induction, because there is risk of hypotension at induction. Central venous catheter is also strongly advised either before or after induction of anesthesia, because patient is mostly will be requiring vasopressors and they may present sepsis. And at least 2 large bore peripheral IV cannula should be inserted before induction. And urinary catheter is mandated for monitoring of the urine output. Now, which fluid should be given? Choice of fluid depends upon the clinical situation. Mostly balanced crystalloid like plasma light, RL you can prefer. And in case of blood and in case of anemia, thrombocytopenia or coagulopathy, blood and blood products may have to be given. Because of their association with the kidney injury, coagulopathy, synthetic colloids like Hestat are no longer indicated. And now, how much fluid should be given? Too little fluid can cause hypovolemia, inadequate tissue perfusion, and too much fluid can cause tissue edema, pulmonary edema, impaired oxygenation. So, current evidence suggests that you should use goal-directed fluid therapy. If available, arterial catheter is put and cardiac output monitoring can be done, PPV, SVV, pulse contour analysis, esophageal Doppler. These are the best measures to do the goal-directed fluid. But if we don't have the access of goal-directed fluid therapy or cardiac output monitoring, we should have the clinical parameters also. Use of clinical parameters, for example, passive leg raise test, capillary refill, tidal volume challenge. All these can be used to assess the fluid responsiveness preoperatively. Before induction, you have to do this test to assess fluid responsiveness. Vasopressor infusion may be required in the phase of fluid-resistant hypertension. So noradrenaline is the first line vasopressors, and other vasopressors are like vasopressor, phenylephrine can be used. But one thing, vasopressor should be avoided in gut ischemia. Going to analgesia, inadequate analgesia may also lead to postoperative pulmonary complications, cardiac complications, thrombotic complications. And if we use high dose opioids, it can cause postoperative sedation. So there is a dilemma, it can cause respiratory depression, ILS. What are the techniques to minimize the use of high dose opioids in these patients? We can use central neuralgic strategies like epidural and spinal analgesia. But they also have concerns, like if patient has hypotension, patient is in coagulopathy or sepsis, we cannot use epidural. We should avoid. These are contraindicated in that case, because rather it can more harm the patient. It can cause more hypotension. It can cause epidural hematoma or abscess. So we have to individualize this approach, whether to use it or not in particular patient. Then we can use a tab block, rectus sheath block, multimodal analgesia like IV lidocaine, ketamine, magnesium for the management of pain. So controlled ventilation, normal tidal volume 8 to 10 ml per kg can be used with addition of PEEP, and inspirative flow rate should be adjusted to minimize the peak airway pressure unless patient presents with ARDS. These strategies can be used. Prevention of hypothermia should be done. Use of forced air warming devices or fluid warmers can be done, because hypothermia itself is a risk factor for coagulopathy and wound infection. Now coming to postoperative management, whether we should extubate or not, it depends upon many factors. It depends upon patient's acid-base status, oxygen requirement, vasopressor requirements, temperature. And before extubation, it is prudent to aspirate an indwelling nasogastric tube and suction the pharynx. So surgical factors are also important for the decision of extubation. For example, in which a surgeon wants to have a second look in 24 hours. Patient is best managed with sedation and ventilation in the ICU. Critical care provision is mostly appropriate for all these patients. And P-Possum score should be recalculated using the accurate intraoperative findings. So admission to critical care should be based on the risk status of this patient. In postoperative also, we should avoid hyperglycemia, hypoglycemia, and optimize nutritional status. Mostly after laparotomy, enteral nutrition is avoided for a period, and parenteral nutrition is used to attempt to prevent malnutrition, sarcopenia, and weakness. However, recent ESPEN guidelines suggest that oral intake should include clear fluids within hours after surgery to most patients. And we should use thromboprophylaxis. So finally, this is the conclusion which I have told. This article in BJA also highlights this emergency laparotomy pathway quality improvement care bundle. It also just suggests all these things: early assessment and resuscitation, early warning score within 30 minutes, and surgical review within 30 minutes, measure of arterial lactate and prompt fluid resuscitation. Early antibiotics within 1 hour, sepsis is there, and within 3 hours if there is suspicion of intraperitoneal soiling. Prompt diagnosis and early surgery, CT scan as soon as possible, then goal-directed fluid therapy, and postoperative intensive care for all. So take-home message is that preoperative BP values may be used to define perioperative BP target. There is no fixed target to obtain in patients of hypertension. We have to decrease BP by 20% in case of hypertensive emergency so as to maintain organ perfusion. And emergency laparotomy itself is a high-risk surgery. Combined with the uncontrolled hypertension, it's a very, very high-risk surgery. So preoperative optimization, risk assessment, appropriate anesthetic management, it may improve prognosis. And emergency laparotomy pathway, which I have highlighted, it should be followed in patients with acute abdomen to decrease morbidity and mortality. And our target should be restoration of the physiological parameters, MAP and urine output. Thank you so much.
Thank you, Dr. Shakshi. You have made an excellent presentation covering all the medical aspects of the disease per se, as well as management of the case what has been allotted to you, the gastric perforation case with uncontrolled hypertension. But I would like to add upon a few points. Blood pressure measurement per se must adhere to standard technique in order to obtain a reproducible measurement representing the patient's true blood pressure. What we call as white coat hypertension and stress-induced hypertension in a hospital environment is very common, and it may be misleading many a times, presenting as what you say uncontrolled hypertension. So the history is very important. The patient is taking medicines properly as per the dosage and continuity of the things, and you have to eliminate one important factor in a surgical setup, especially the pain component of the surgical illness. If that pain component is removed, most of the times the blood pressure per se comes down, the mean arterial pressure comes down. That would have been observed by all the anesthetists per se, and even in an emergency setup, keep that in mind. And don't over enthusiastically treat the hypertension, because hypertension is more dangerous than hypertension per se. The elevated mean arterial pressure can be a normal thing for that patient over a period of long duration. Whereas the LV function, if it is not adequate enough to accommodate the vasodilators or the drugs what you give, may be harmful sometimes. So that is one point I would like to say. And all hypertensive patients ideally should be treated before elective surgery. That is accepted. But in practice, only patients with stage 3 disease require a preoperative treatment per se. Importance of the isolated systolic hypertension per se is not well defined in any of the literature what I've gone through. Maybe the seniors can elaborate. Patients with the moderate hypertension, according to your classification, stage 2, with the end organ involvement, may also require preoperative optimization. You should not eliminate those cases as normal cases. And then most antihypertensive drugs do not have any adverse effects with our anesthetic agents. So they can be continued except for the AC inhibitors. That is a question routinely asked in the exams for the PGs. So you know what are the mechanisms involved and all those things. So you should have an array of IV antihypertensive drugs, commonly used ones, with you in an emergency setup. Okay. Regarding this clinical aspect of the gastric perforation per se, most of the times the gastric perforation, if it is presenting to you in an early stage, you will not have that sepsis component too much, the effects of the sepsis per se. If it is a late presentation, then you have the septicemia involvement and the septic shock scenario, and more of the acidic peritonitis influencing the disease outcome. So the morbidity and mortality is increased when you have a late presentation. Early presentation will not have such a scenario. The acidic peritonitis is the thing, component to be involved. Aspiration, as you said, has to be taken care of. You have to empty the stomach contents through an NG tube, probably with a wide bore NG tube preoperatively prior to induction and intubation. A rapid sequence intubation and the thing, Selleck's maneuver, all these things has to be followed. More practical aspects of the things. Can an epidural be initiated? Yes, definitely an epidural can be initiated. No harm in that. What is the choice of having an airway involvement device? Is it an endotracheal tube always, or can an alternate things be considered? I would like to secure the airway with always an endotracheal tube with a cuffed one with the NG aspiration prior. If at all you anticipate any difficult intubation scenario, you can go ahead with the proceed and can have a continuous suctioning option there. Another aspect, surgical aspect, you have to think in mind always. This perforation per se may not be a benign perforation as you think in peptic ulcer disease. It can be also a malignant perforation. So in case of malignant perforation, the surgeon will proceed on with a gastrectomy, a partial gastrectomy or a total gastrectomy on table. So you have to be mentally prepared to handle that case also. Okay. It is not a simple patch closer or a simple primary suturing or thing. So it involves which part of the stomach is involved. What is the thing? You cannot diagnose with the pathological means and then go ahead with the surgery. On the table, the surgeon sometimes may think it is a malignant lesion, so they go ahead with the gastrectomy. So you have to be prepared with the blood and things, and you have to plan for the post-op things also. If you think the sepsis is over, mean, it's a thing, no, you cannot decide upon the extubation. So you follow the extubation criteria also meticulously. Don't over enthusiastically extubate the patient with such a big comorbidity and illness, the gastric perforation. Okay. So the acid peritonitis, the sepsis has to heal. The antibiotics have to cover the organisms involved, and then the optimal physiological condition arrives. That is the time you plan for extubation, not on the table extubation. Heroism is not at all required on the table. Elective post-op ventilation is a good option also. So don't think it is your failure to not extubate case on the table in the theater. Okay. Yes. Sir, ALM sir, please take over, sir.
Well, no. You please ask. See, there are so many chat box questions. Let me hear it from the speaker.
Yes, sir.
The majority of the questions are directed to Dr. Sakshi, as it is a regular practical point. But before that, I want to check. See, these people were introduced to me by Dr. Lalit Kumar Raigar from Rajasthan. I think Sir is here. First, we will have his comments. Sir, you are here, Dr. Lalit Kumar Raigar, sir. Dr. Raigar, sir. Yeah, I think Sir may join, but before that, before the chat box questions are thrown open to the Dr. Sakshi, I want to ask, Madam says you have to ventilate with the 8 to 10 milligram per 8 to 10 ml per kg in elective post-op ventilation. But your hubby says it should be only 6 ml per kg to avoid lung injury. So whether you are standing on your own statement or just like a spouse, you want to contradict each other. Like,
Sir, in case of ARDS or we should use low tidal volume, 4 to 6 ml per kg. But in normal patients, we should use 8 to 10 nm per kg, because low tidal volume can itself cause hypoxia and they itself cause lung injury. So they can precipitate hypoxia. So in normal patients with no evidence of ARDS or acute lung injury, we can use 8 to 10 ml per kg.
So you want to contradict Dr. Nirdesh? That is fine.
That is only in case of ARDS, sir.
That's good. That's a good point. But
No.
see, all the people.
All major cases are prone for acute lung injury in the post-op period. So that has to be kept in mind. We voluntarily should not cause any barotrauma or polytrauma.
8 to 10 is, madam,
Yes, sir.
8 to 10 is large tidal volume only. See,
I
even
would
in
go for 6 ml.
even in Shillong, I said, when I was a postgraduate, I was ventilating with 15 ml per kg tidal volume. Once I became an assistant professor, I was ventilating with 10 ml per kg. Once I became a chief, I am ventilating with 6 ml per kg. Things are changing, but he has also produced the acute lung injury slides very carefully. It is very good. Madam, the question to you is whether it can be practiced under thoracic epidural anesthesia or segmental spinal anesthesia. If the vitals are stable, what
Yes,
are the
sir.
pros and cons?
Yes, sir. This is a new technique introduced right now by Shiv sir on the anesthetist group. And I have also used personally this technique. This is a very good technique, thoracic segmental spinal. It blocks only the particular segments which need to be blocked. And mostly we use the isobaric or hypobaric drugs in this segmental spinal. It is a very good technique. You can use it. It has a very less hemodynamic disturbance. But the only thing is you have to choose the patient. If patient is drowsy, if patient is in sepsis, if patient is hemodynamic unstable, and if patient is in coagulopathy, then you have to be cautious. So in every patient you cannot use, but yes, it is a good technique. If there is
Then, madam,
no coagulopathy, you can use thoracic segmental spinal.
Next question to you, you suggested mannitol. Someone wants to know what is the dose of mannitol. Sir, you are in the webinar, sir.
Sir, it may
Does mannitol per se have
pulmonary
any effect on
edema.
the- Only for cerebral edema, documented cerebral edema or intraocular pressure rise. If it is documented, you have to use. I don't think it has a big role here.
Yes, sir. Rather, it may be harmful for this such type of patient. It may precipitate AKI in such patients. It may precipitate pulmonary edema.
Mannitol is controversial in this scenario.
Yes, sir. It is particularly used in raised ICP.
Low dose mannitol can be used for perfusion, increasing the perfusion. But for that also, I don't think it has got a evidence-based backup on.
Yeah,
I don't think
there's
maybe
no,
some clinicians
not
may
much
be using
evidence.
it in that setup.
Yes, sir. Rather, it may.
Any other questions from the audience? So, what is the blood pressure to postpone an elective surgery? Current consensus guideline, ACC/AHA guideline. What do you follow in your institution, madam? You are muted. Your audio, please.
Yes, sir. We are following NICE guidelines, sir. 2019 update of NICE guidelines.
Yeah.
ACC/AHA guidelines have defined the fixed target of less than 130 by 80. So it is not possible to that one
Achieve.
size fits all. We cannot fix one target for all patients. It has to be individualized. So NICE guidelines are the most widespread and most widely acceptable.
Okay. In hypertensive urgency, whether to optimize the BP before emergency surgery or not, madam? There is a question for you, madam, in the chat box. Yes, I think
Hypertensive emergency, there is no target organ damage. So this is hypertensive urgency. It can be because of the pain or current situation of the patient, because of abdominal rigidity, because of abdominal distension. So we need to rule out whether this is because of primary hypertension or it is because of the current situation of the patient. So it can be, BP can be decreased gradually in such patients. Mostly anesthesia drugs will itself cause it decrease BP. So it is not necessary to decrease BP immediately in such patients. BP can be decreased gradually. And we have to first differentiate whether end organ damage is present or not, because treatment will be different in both cases.
how much of fluids you will resuscitate prior to taking up such a case, a gastric perforation case, in your experience, doctor?
Sir, ideally, if patient is in sepsis, then 30 ml per kg as per sepsis guidelines. But yes, we have to first see the fluid responsiveness of the patient. We'll assess about capillary refill, passive leg raising test, and tidal volume challenge, and all these parameters. We have to assess
You can always use an
heart rate,
ultrasound.
arterial
IVC
blood
can be a
pressure.
good indicator of the intravascular volume component. You can check with an ultrasound.
Ultrasound also, sir. IVC, we can see.
Good procedure to check the status of volume. You
Yes.
should not volume overload also. But there is a deficit always. Generally, in our clinical experience, we have seen the volume deficit is large, quite large. It requires around 30 to 50 ml of proper replacement solution. Okay.
Yes, sir.
So that aspect has to be not over. You have to have a good urine output prior to taking up this case, so that you don't land up with the AKI in a post-op setup. AKI is very common in such cases. So as far as possible, we try to avoid AKI also in the setups. Any other questions in the chat box? Any audience queries?
Yeah, here, Chairperson
Yes,
sir,
sir.
Dr. Jayarani from Tanjavur has thanked ISA Pudukkottai for selecting a wonderful topic. But a wonderful topic were selected by the wonderful speakers. Now I want to ask Dr. Kunal Moody, how many cases of carbon monoxide poisoning you have seen?
Sir, we rarely find carbon monoxide poisoning cases over in our setup, sir. I have myself particularly seen 1 or 2 cases hardly in this ICU setups and emergency calls wherever we get.
Carbon monoxide poisoning?
Yes, sir. One we have seen of cyanide, sir, and 1 or 2 patients of carbon monoxide.
No, what I'm asking, how you have diagnosed the patient as carbon monoxide poisoning, how he has landed. The idea of me asking this question is that is the reason why questions are not directed to you. It is a very rare type, but unfortunately, it is a question for you. So if carbon monoxide poisoning is coming as a university question, you will score distinction. So, Dr.
I
Nirdesh.
hope so that comes as a question in our
Yeah,
university
I wish
examination.
if I am the examiner, I will do that. Dr. Nirdesh, I want to ask you whether you have personally seen a ARDS victim has recovered completely by this ECMO therapy. Sir, your audio is not this thing.
Is there on the line, Dr. Nirdesh? Dr. Nirdesh probably has muted.
Dr.
Yes, sir.
No, probably Dr. Shakshi would have muted him.
Yeah. Yes, sir. I have seen many patients coming out of ECMO, especially during my FNB period in Gangaram. Even in majority, I saw in Fortis, Gurgaon, very good center for ECMO. So I basically learned there. And so I liked ECMO so much. That's why I went for in Sweden to pursue observership and ECMO course.
When you are instituting, when you decide this patient is to go for ECMO?
Sir, in our Indian scenarios, first and foremost thing is expenses. But clinically, yeah, I include Murray score and as early as possible, within 6 hours. Sir. As early as possible means if you should take decision within 6 hours, counsel to the attendants. It may take these days, how many days we can't predict, but it surely works because it gives complete rest to lung, because we have to set minimal PEEP and minimal tidal volume just to aerate lung.
No, my question is straight. See, you are ventilating the patient with the low tidal volume, low PEEP. Then you are trying prone. I'm asking when you will decide, right? This is the time we have to go for ECMO. No, IPPV will help.
Yes, sir. After giving prone session, after giving one prone session, if oxygenation is not improving, then in that we used to this practice in Fortis, Gurgaon in India actually. In foreign they use immediately, but in India, after if we fail in one prone session, then we immediately counsel patient to go in ECMO as oxygenation is not improving, or refractory respiratory acidosis. That is a very big challenge because sometimes patients come with pneumonia with septic shock also, sir. So in that scenario, we use VA ECMO, that is veno-arterial ECMO. So it supports BP also. So in case of myocardiopathy and lung involvement or sepsis, all parts will be covered. So that is the way.
Now, Dr. Nirdesh, the great man, Dr. Lalit Kumar Raigar, is seen in the webinar. I request Dr. Lalit Kumar Raigar to present his views about Pudukkottai Budan or about the subject. Sir, please unmute, sir. You can unmute yourself. Yeah, please, sir.
Thank you, sir. Good evening to all. And whenever I have time, I always attend your Pudukkottai webinar as a regular feature. And thank you, sir. You had given opportunity to Udaipur, Rajasthan. I have selected, I think they had justified their role. Am I right, sir?
You have justified your role, sir.
No, we had selected all two faculties. No doubt they are spouse, and my PG also.
He's also, sir. He's also. They are trained not only in anesthesia. They want to settle in their life at the time of post graduation.
Yes, sir. Yes, sir.
They take it as the right moment.
These are the nice topics, as you had said on the first. Definitely, we will present, and they had presented. And Dr. Sakshi has well elaborate all the things that theoretically as well as clinically. That is practical one. And she has elaborated all the points that has to be taken care for the PG exams. And definitely she has included the all guidelines. Likewise, Dr. Nirdesh has done very well, as well as including the historical parts and the latest one. And the Modi has also done, and young chap, he has done well. As well as Dr. Karthik has makes some inputs that make the all three topics complete. Whatever our speakers has left, something practical tips. Dr. Karthik, thank you very much, sir.
Thank you, sir. Thank you for your kind words, sir.
Sir, actually, we have listened to Arjuna's. Now we are listening to Dronacharya.
It's your blessing, sir.
Thank you very much, sir, for your kind patronage. Keep on introducing people like these young faculties. They're too good.
And since the social gathering, that after 3 days, after Shillong, we are again met with this webinars.
That's right, sir. This is too homely than Shillong. Because even I wish I should have studied in Rajasthan so that I could have settled like this.
No, sir. You are most welcome, sir. You are most welcome. I am in both Udaipur as well as Mount Abu. At present, as I mentioned you, leading the new medical college in Mount Abu.
Yeah, we will visit Mount Abu, sir.
Yeah, sir.
Thank you then. Definitely. Thank you very much, sir. Chairperson, can we hand it over back to the President ISA Pudukkottai?
Yes, sir. Thank you for the opportunity given to me, sir.
Yes,
thank you so much.
Sir, please, President, sir, please take it over.
Yeah. Now we are ending the CME as usual. 37th CME Pudukkottai Budan. It's very good, very nice. The presentation.
148, President, sir, 148 speakers participated.
Yeah.
148 is not a simple number.
All the three speakers presented very well. Exceptional presentation. Excellent and outstanding. And all the three speakers spoke with the authoritative style. That is the outcome of this today's speaker, this CME. And I thank Dr. Sakshi Thakur, Dr. Nirdesh Thakur, and Dr. Kunal Modi for coming here and giving their inputs here. Our chairperson, Dr. Vijay Karthik. Thank you, sir. You have spent the whole evening with us. You have wonderfully navigated the whole session, and you gave useful inputs also, your practical things in addition to their talks. Thank you very much, sir.
Sir, President, sir, Karthik has given the top-up dose. For everything, top-up dose he has given.
Yeah.
For all the topics.
Yes, sir. Right, sir.
Yeah. It's understood.
Thank you,
Your talk itself shows you are a very practical man, sir. You have contributed all the practical things in that topic, sir. I thank our academic chairman, Dr. A.L. Meenakshi Sundaram, sir, for his guidance and support. I thank all the delegates who attended this session and to take their. I welcome. They have attended the whole CME in full session, and I thank our office bearers of Pudukkottai ISA branch who are giving wonderful support. My thanks goes to Acrola Pharma and A1 Logistics for the technical support. Thank you. We will end the session and we will meet in the next Wednesday in another session. Thank you. Thank you all.
Thank you all.
Thank you, sir. Thank you all.
Thank you so much, sir. Thank you.
Thank you, sir. Thank you so much.
Kunal, you look like a Salman Khan.